Good afternoon, ladies and gentlemen. It's with great pleasure that I introduce our speaker, Professor Lieselotte Mettler, also known as Lilo Mettler to her friends. And Professor Mettler was born in Vienna, Austria, and finished her medical studies in Tübingen, in Vienna, and in Kiel. From 1981 to 2007, she was the Deputy Director of the Department of Obstetrics and Gynecology, University Hospitals at Schleswig-Holstein, Germany. And from 1995 to 2017, Director of Endocrinology, Reproductive Medicine, and Gynecological Endoscopy Surgery. Her main fields of activity are reproductive medicine, gynecological endoscopy. She's written over 1,000 publications, 25 books, 9 textbooks. She's currently Professor Emeritus at the University Hospitals of Schleswig-Holstein and the Honorary Patron of the Kiel School of Gynecological Endoscopy, which she headed before. And since 2003, she's Director of the Department of Gynecology, German Medical Center, Dubai Healthcare City, and she's Honorary Member of the German Society of Obstetrics and Gynecology, of the German, European, and American Society of Gynecological Endoscopy Surgeries. And in 2020, she was awarded with the honorary membership of the American Society of Gynecological Obstetrics and the Cross of Merit of the German government of the state of Schleswig-Holstein in Kiel, Germany, where she's been living since 1961. In November 2023, she also became an honorary member of the American Society of Gynecological Laparoscopy in Nashville, Tennessee. And I first met the professor in 1972 at the second meeting of the AAGL in the Stardust Hotel in Las Vegas. I was quite young at the time, and it's a pleasure that I get to meet her again.
Thank you very much for the nice introduction. It's a big pleasure to visit Cairo again. Actually, my first visit was in 1959. I had just graduated from high school, and a good friend of the family was a lawyer consultant in Ain Shams, and he took me along to one of his talks to Ain Shams in 1959. I didn't know that it was founded in 51. I learned this here. So it's a big pleasure to be back and talk to you on minimal invasive surgery, the history today and the future. We went in laparoscopy from a bent position and direct vision to video laparoscopy, and finally to sitting and ergonomic position and working situation at robotic-assisted microinvasive surgery, either vaginally, single or multiple port entry, and have the vision for more to come, like automatic surgery. And you mentioned, it's my pleasure, the Kiel School of Gynecological Endoscopy that was founded by my teacher and myself as a helper at the time in 1970, and you were visiting in 72, that we're still working with it, and are also a major robotic center trying to enter artificial intelligence wherever we can, in good cooperation with other specialties, urologists, general surgeons. Congratulations to ASOGIC 27 for this splendid meeting. It's my pleasure to come. We went in laparoscopic surgery historically from air insufflation to today's robotic endoscopic surgery. It was a rocky road. In 1901, Georg Kelling performed his first endoscopic surgery viewing the stomach of a dog. This is considered as the birth hour of endoscopic surgery. Where are we today? He started that in Hamburg in the House of the Natural Scientists with Nitz's cystoscope and his air insufflation mechanism. This video shows endometriotic cyst removal in the early years. I think it's a video of 1980, 82, something like that. You can see how not excellent the vision was. And if we have today such a picture, nobody is satisfied. But still, we did endoscopic surgery in those days, and were, of course, not accepted by many people, and there was a long and rocky fight to be accepted as a specialty. Today, we do in Kiel a lot of robotic surgery, like this is a sarcocolpopexy. It's one of the cases we did in a course last year. I'm still operating courses in mostly robotically. So it's a pleasure to see and have been current witness of the development in endoscopic surgery. The goals are the same, whatever technology we use, vaginal laparotomy, laparoscopy, robotic. We would like to help our patients. What procedures can we do today? Just a survey. In benign cases, nearly 100%. That's how Kurzem envisaged, including hysteroscopy. In malignancy, we do on the cervix, in spite of the studies of the LUX study, again, good cervical manchetta. We use no manipulators, and we are back to do endoscopic surgery in cervical cancer, endometrial cancer, ovarian cancer, sentinel lymph nodes, and with many other indications, specific individual indications that all of us use in combination with general surgeons many times, and we don't have time to go into details. Just a few examples: a simple myomectomy, a little more difficult one in the lower picture, and a robotic one in the right lower picture. So we are standing, we're not bent anymore, we don't look directly, we enjoy the good video laparoscopy, and myomectomy is becoming an easy procedure. In this case, we had a patient admitted with a heartbeat and 2 uterine bodies. What can that be? Laparoscopy can find the clarification: a non-commiated uterine horn, a robot's uterus. And it was then easy to go in, take the non-connected horn and the right tube out, and help the patient, because she would have had a rupture. Today, we are not able yet to control these cases totally and to help the baby to be born at the right time. So the resection follows of the not connected uterine horn and the right tube, and then incorporation endoborg and extraction. Here's a patient that 1 year after C-section, she went from one doctor to the other one with abdominal left pain. She finally landed with us, and what did we find? A remnant of a tissue that was left inside that had formed a tumor between the uterus and the bladder. So it was actually a foreign body that had formed a tumor, laparoscopically easy to take out and retract, and to take this pseudo tumor away, and the patient was without pain. So we are forced to understand well what we can do to do good surgery. So prerequisites are that we know the clinical anatomy, we know how to get into the abdomen, how to cross the abdominal wall, how to look in the retroperitoneum, and what happens at the pelvic floor. So these areas, once really known to us, give us a good possibility to work. Let us take total hysterectomy for an example. It was described by Dieter Raths, Kurzem, Harry Reich. Harry Reich had his 83rd birthday yesterday. So it was also a good friend that we have good connections with all the time still. What do? We have to understand the connecting of the vessels, from ovarian vessels, uterine vessels, how they come together. For uterine transplant, that's important. For hysterectomies, that's important. Understanding the anatomy, it's easy to dissect a uterus out from the pelvic sidewall, from the bladder, open the vesicovaginal space, go down to the vessels. In total laparoscopic hysterectomy, we use manipulators to pull up the uterus. And like this, we put all these hysterectomies also in a book together that we published 4 years ago with Springer, comparing all hysterectomy techniques. Anatomy is a prerequisite. So we have to understand how the peritoneum is covering the pelvic organs. What do we find under the peritoneum? Where are the vessels? How can we activate the ureter? How can we see the ureter? It's not strikingly yellow as here, but we still can see the ureter well. How does the pelvic floor look like? What are the support ligaments, sacroiliac ligaments, cervical ring? Where can we do support surgery in urogynecology? Knowing this, where the lymph nodes are in cancer surgery, knowing different bundles, understanding the nerves, how they are running, we can really do good surgery in the paracysticum, paracolpum, and the paraproctium. We exercise this on body donors, and training of our assistants on body donors and visitors in courses has been our effort since 25 years. I established at that time in our anatomy department the first trainers that we had, And now we do active surgery also on body donors that are ethanol glycerol fixed, and we have time and can explain the different surgeries to visitors and to colleagues within the educational program. It looks a little bit different, it does not bleed, but still nearly all the structures can be seen. This is the exploration of a female pelvis. You can see that all organs can be carefully studied. In this case, we compare subtotal hysterectomy in a life situation to a body donor situation. And it is very easy to also go ahead here, if I can get that, but I don't, never mind. But it is easy to compare, and we get a good way of learning it. In subtotal hysterectomy, we bring in the Röder loop and dissect electrically the uterine corpus from the uterine body, from the cervix. In total hysterectomy, this dreamt of colpotomizer is in development, that we can electrically do it. It's not there yet, but I'm sure it's going to come. Comparing the cervical stump of body donor and patient shows you that there is not a big difference. Past and present available robots in gynecologic endoscopic surgery for multiple and single port entries are primarily the Da Vinci system, with which we have very good experience, but also with experience with Dexter, Sinhans, the Korean robot, Chinese robots, the Versius, and many are going to come, also in smaller way, so we can foresee that this intelligent surgery will be possible. In our operation theater, we have a console where the surgeon is working, and the training console where the assistants can learn how to do robotic surgery. And it's a pleasure to see here also my colleague Ibrahim Al-Kartout, who is now the leader of our Kiel school since 10 years. Example, in endometriosis, we can really do all the surgeries robotically, in my understanding, better. We use in Europe the NCN classification, where we can see lesions on the peritoneum, P, ovary O, tubes T, then the rectovaginal endometriosis under ABC and other locations easily. And if we then go into the abdomen in the robotic case of a resection of endometriosis, stage 3, with endometrioma, we can nicely find the layers and see the advancement in moving the instruments. So we went from laparotomy to laparoscopy in a standing position to robotic surgery in a sitting position again. And we know the advantages of the robot system, which clearly is the movement of the hands 360 degrees and many other little details. The renaissance of abdominal surgery is back to the fingertips in robotic surgery. We can train on the robotic trainers in comparison to the conventional trainers in our center. And once you train it in the robotic trainer and the conventional trainers, all gives you a good possibility to advance technologies. This is a Da Vinci trainer where we can even do hysterectomies, exercise them, individual parts of hysterectomies, and I'll just play easily. On the upper left one, you can nicely see how we can localize with a foot movement the position of the uterus, and then bring in the adequate instrument. Once we have done a hysterectomy on the trainer, it results, of course, easily to do it on the patient. This is here now a conventional total laparoscopic hysterectomy, and we see the advantage of the preparation, and we can slowly go onwards. Yeah, I don't manage to advance, doesn't matter. So we have many possibilities to do myomectomies and morcellation than in a bag, or enclosure of the wound with robotic surgery. To your lower right is the closure of the vaginal cuff with robotic surgery. We like to use ECG. So that's unfortunately loud, so I didn't kick it. I like to use ECG just once I go back to show the uterine cavity. This is a case of a myomectomy, and unfortunately it's the sound connected, so I cannot take that off. But here you can see after we've taken the fibroid out, we close the wound just like we do it in open surgery. With robotic surgery, this myomectomy took 30 minutes, and it was a 800 grams fibroid. So the advantage is given. We enjoy to do it. This is one of the first robotic surgery we did in 2005, 2006 with the Da Vinci. Again, it shows that it has improved. The light we have today is much better than you've seen in the fibroids, but still we could do tubal anastomosis. In that time, that's nearly 20 years ago, with the Da Vinci robot, and we did first 20 tubal reversals before we started with other surgeries. So we did go ahead and use modern technologies like AI to advance endoscopic surgery that 50 years ago was considered to be really experimental and not a good surgery. My dear colleagues, let me end that endoscopic surgery today and tomorrow, the goals are the same. Recognition of relevant pathology, possibilities of radical cure if necessary in endometriosis and cancer, minimal trauma, bleeding and tissue laceration, adhesion prevention, preservation of intact urogenital tract in patients of reproductive age, of course also in advanced age. Then also we have many indications we want to do that. Molecular targets to be addressed in cancer surgery. But what makes you really a good surgeon? And I would like to end with that. Knowledge of anatomy, knowledge of newest technologies. Be open for new technologies, whether you can afford them or not at the moment, but be open to understand them. Availability of best instruments and apparatuses. Love to God, to our profession, and to our family and friends. Thank you very much for your invitation.
Thank you, Professor Mettler, for a wonderful lecture. And as you said, the technology is moving forward, and robots, there are over 50 surgical robots currently going onto the market within the next 2 years. Our next presentation is a pleasure to introduce Professor Dr. Hatem Gamal. He's president of the conference and professor of obstetrics and gynecology at Ain Shams University, and he's going to be talking about the role of laparoscopy in ART currently.
Thank you, Mr. Chairman. It is difficult for me to follow Professor Mettler. She was my senior professor, and she was one of the supervisor of MD thesis in Kiel. Here I want only to concentrate about the role of laparoscopy in the era of the RT, so the role of laparoscopy in infertility. Here, this is the Frauenklinik der Universität und die Michael-Zepam-Schule, directed by Senior Professor Kurt Zem. Here is Professor Zem. This is the professor, my MD thesis was in Kiel with Professor Kurt Zem as one of the most critically acclaimed fathers of laparoscopy. He is German engineer and gynecologist. Introduced the automatic insufflator, thermocoagulation, loop knots, irrigation devices in 1983. Performed endoscopic appendectomy or appendectomy as a part of gynecologic procedure. In 1970, after becoming the chairman of obstetrics and gynecology at University of Kiel, his co-workers demanded that he must undergo a brain scan because he said only person who with brain damage would perform laparoscopic surgery. And nowadays, everything we can do with laparoscopy. He is the father of modern laparoscopy, Professor Zem. And here is some pictures with Professor Zem and with his young son. Here with Professor Zem in the operating theater. Here with the pretty Lily Mettler or Lilo Mettler beside Professor Zem. And here with also Professor Zem in another. He's with Professor Daniel Darjan and Professor Harry Reach. All those are the fathers of modern laparoscopy. The advancement of the new perspective in assisted reproductive technology through the use of the modern infertility evaluation technique, still clinician needs to reassess how infertility should be treated. Recently, the focus of treatment for infertility has shifted from systematic correction to each identified factor to applying the most efficient therapy, which is the assisted reproduction. And there is a debate between always reproductive surgery by endoscopy or by the assisted reproduction or IVF. We have in endoscopy some advantages. It will restore the normal anatomy, enhances natural pregnancy, and also repeated pregnancy can occur. And ART, this is the advantage of the endoscopy. Disadvantage of the endoscopic surgery needs surgical expertise, of course, the procedure-related complication, and the operation risk. However, the ART is time-saving with good results, but it is expensive, and our nightmare is the ovarian hyperstimulation syndrome. Debate is complex in regards to the age of the patient, the ovarian reserve, the previous management, whether surgery or ART. Can ART replace endoscopy in the field of infertility? Endoscopy and ART are complementary and not supplementary. First child was ovum pickup retrieval by laparoscopy. Still laparoscopic egg retrieval is required whether ovaries is inaccessible. What is the best approach? ART or laparoscopy? Actually, we need to individualization, case selection, time, and the pathology or the disease. Justifiable use of laparoscopy in infertility. Number one, unexplained infertility. No definite cause of infertility could be detected after meticulous search for all possible causes for 1 year. This is the definition of unexplained infertility, and it is justifiable to do laparoscopy for those patients with unexplained infertility. Number subtle, in unexplained infertility, we may discover subtle forms of the endometriosis. Of course, the apparent causes of the endometriosis or the apparent diagnosis of the endometriosis by the ultrasound, and the chocolate cyst can easily diagnose. No need to do for those laparoscopy, and we always said that it is a crime to add the laparoscopy for endometriotic patient because it will affect markedly the ovarian reserve. But in case of unexplained infertility, you may find subtle forms of the endometriosis. You may find the clear plebs, white, yellow lesions, blueberry lesions, powder guns. For example, this is a clear endometriotic pleb. You can find this, and if you take a biopsy from this, you will find endometrial glands. So this is, you can diagnose mild form of endometriosis by this way. And this is the raspberry lesion. This is the only lesion you find on the uterus. This is the raspberry lesion, and it may cause infertility through the act on the cytokines and the peritoneal factor or the peritoneal cause of the infertility in cases of the endometriosis. And this here is the strawberry lesion or the blueberry lesion. You can find here again, but here you can find that there is gravium follicle here, and this is the tube is okay. But so the cause of the infertility here is also through the peritoneal factor of the infertility through the release of the cytokines. And we may find these gunpowder lesions through the laparoscopy, and sometimes if we cauterize these small lesions, we'll find following 3 or 4 months following this procedure, the patient got pregnant. And also this is another form. These are the, also we may find occult genital infection. Occult genital infection, for example, chlamydia, and here is the Hooker's syndrome, where we find the hepatic adhesions is diagnostic of the chlamydia infection. This is again another causes of unexplained infertility. What the benefits of the laparoscopic surgery? Spontaneous pregnancy in mild disease, In mild disease, in case of the endometriosis, elimination of the pelvic pain with destruction of the peritoneal endometriotic lesions and to confirm the diagnosis histopathologically. But now this was in the unexplained infertility, but in endometriosis, this is clear chocolate cyst. This is clear chocolate cyst. And we have the laparoscopy in this has no role except in two cases. If there is complicated cyst with severe pain, and the second is it is inaccessible to retrieve the oocytes in the presence of these chocolate cysts. So this is the ESHRE recommendation for the management of the endometriosis by the laparoscopy. Risk of laparoscopic surgery in case of the endometriosis: decrease the ovarian reserve and the loss of the ovarian tissue, premature ovarian failure in about 2% if it is bilateral, and decrease the oocyte number and the quality for the IVF. And this is the recommendation, as we said. There is 8 studies included, about 237 patients underwent cystectomy for unilateral or bilateral endometriomas. The weighted overall average preoperative anti-Mullerian hormone or AMH was 3, and this fell statistically significant by about 40% post-operative. This study with best laparoscopist management, it will fail about 40% with the use of ideal laparoscopist or very expert surgeon. So this is the ESHRE recommendation, as I said. In infertile women with endometrioma larger than 3 centimeters, there is no evidence of cystectomy prior to treatment with assisted reproductive technologies improve the pregnancy rate. In women with endometrioma larger than 3 centimeters, the GDG or the guideline developing groups recommends clinicians only to consider cystectomy prior to assisted reproductive technologies to improve endometriosis associated pain or accessibility of the follicles to be retrieved. In case of uterine fibroid, the management of the fibroid, of course, we know that all the intracavitary we can use, but this is hysteroscopically. The doubt about the intramural fibroid, which is about more than 5 centimeters, it is advised to remove the intramural fibroid before the IVF, even if not touched the endometrium. Again, with good laparoscopist and without complications, without opening of the cavity causing Asherman syndrome for the lady. Removing uterine fibroids surgically according to the location, the size, the equipment, and the training. Number 4 of the rule of the laparoscopy is the distal tubal block, the hydrosalpinx, and block the tube at the outer and secretes the fluid faster than it is absorbed and becomes enlarged and secretion, and this causes failure of the results of IVF. And it was found that the tubal disconnection before the ART will double the results, they will double our results. So this is the 4th indication for the use of the laparoscopy for the tubal disconnection. This is the picture of the tuber or the hydrosalpinx sonographically. Again, this is the cogwheel appearance during of the sonography. There is signs of the beads on a string. There is no activity in the wall, practically no signs of Doppler. This is for diagnosis of the hydrosalpinx by the ultrasound. Inflammatory and toxic fluid leaks back to the uterus, causing failure of the ART procedure. Surgery for distal tubal disease, limited filmy adhesions, mild adhesions. This is another indication you can do. We can do some laparoscopies in cases of mild filmy adhesions to the periphery of the tubes. Fembryoplasty and the neosalpingostomy in women less than 35. Pregnancy rate depends on the degree of the tubal disease, more favorable with good prognosis of the patient. In case of the hydrosalpinx, if it is mild or severe, the pregnancy rate will, in case of the mild hydrosalpinx, it may reach up to 30%, but in severe hydrosalpinx, from 0 to 10%. So in those patients, we prefer to disconnect the tubes and perform the assisted reproduction. Indications of proximal tubal block, as we said, salpingectomy, extensive dense peritoneal adhesions, massive dilated tubes, and thick fibrotic walls, sparse or absent lumen. Surgical treatment should be considered for all women with hydrosalpinx prior to the IVF, and this is grade A recommendation. What we'll do, we may do salpingectomy, we may do tubal occlusion through diathermy, we may do laparoscopic neosalpingostomy or hysteroscopic approach for corneal block. Actually, we do tubal disconnection in such conditions. It's better than tubal or salpingectomy, because salpingectomy, it may affect the ovarian reserve. Effect of unilateral hydrosalpinx. In the case of unilateral hydrosalpinx, we only disconnect the tube with the hydrosalpinx and leave the other as it is. Technical aspects of salpingectomy, it's not important. Peritubal adhesions is another indication for laparoscopy, adhesiolysis to improve the pregnancy. Number 6, ovarian drilling prior to the ITRT. Ovarian drilling, I think it is a crime to do ovarian drilling for the patient. It is obsolete nowadays. It will affect markedly the ovarian reserve unless you follow rules in case of the ovarian drilling. What is the indication? In fertility sterility in 1960, this surgical approach may be considered as useful technique in the management of patients who have previously developed ovarian hyperstimulation, or those patients with very high level of anti-Mullerian hormone above 12 or 13 nanogram per ml of the anti-Mullerian hormone. This only situation we may justify to do the laparoscopic ovarian drilling. And number 7, nowadays we are in the era of the fertility preservation. Ovarian fertility preservation strategies. We have the fertility sparing surgical procedures, GnRH agonist, of course. These are all the methods. Ovarian transposition, oocyte cryopreservation, embryo cryopreservation, ovarian tissue cryopreservation, and we have a stem therapy. Of course, laparoscopy has a very important role in this fertility preservation. Ovarian cystectomy, for example, unilateral salpingo-oophorectomy. All fertility sparing techniques should be decided after accurate clinical, surgical, and histological staging of the disease. Ovarian transposition is one of methods. This could be applied only to protect against radiotherapy. It could be applied in the colorectal carcinoma, and the ovaries are moved in with intact blood supply from the pathway of the radiotherapy. Spontaneous pregnancy rate after ovarian repositioning in about 11% conceived by the assisted reproduction technique. And this is the method, and this is the laparoscopic how we do the ovarian transposition. In conclusion, laparoscopy still has an important role in the diagnosis and treatment of the infertility. A significant number of infertile women, such as those with tubal factor PCO and women with unexplained infertility, can benefit from it. Operative procedures at the same time, laparoscopy can enhance conception with IVF. Evidence rule of laparoscopy in fertility preservation. Actually, we have in our unit in Ain Shams University, or in the IVF unit in Ain Shams University, we have onco fertility clinic, and in collaboration with the cancer patients in our hospital, we do fertility preservation for those patients, and we do urgent fertility preservation and different types of stimulation, dual stimulation, and we can take or retrieve oocytes from those patients with less than 1 month. Thank you very much.
Thank you very much, Professor Hatem, for this comprehensive presentation. By the way, Professor Hatem is one of the members of the Egyptian German Society of obstetrics and gynecology, and I am pushing him to be the head of this very important society, the Egyptian German Society of Obstetrics and Gynecology, after the late Professor Schindler, who unfortunately left us 2 years ago, I think. So we want to push Professor Hatem to be the head of the society in Egypt this year. Thank you very much, Professor Hatem. I now present Professor Amr al-Husseini, who is the head of our Ain Shams University department, and he is going to talk to us about robotic surgery in DIE.
Good afternoon. My name is Amr Husseini. I am the head of the Department of OBGYN in Ain Shams University. I'm very grateful for the organizing committee for inviting me. I'm thrilled today to stand before my mentor, Professor Munir Mohammed Fawzi Al-Haw. He used to be my supervisor doing my MD thesis. He's the one who taught me everything about hysteroscopy, in addition to a lot of things in life. So I'm grateful and indebted for him all my life. I also see my friend, Professor Ahmed Al-Manawi, one of the brilliant minds in Cairo University. We are very honored to have you here. And I see Professor Metla here from Germany, and Illuminati in the field of minimal access surgery. We are very grateful to have you here today in the conference. The robotic surgery in Egypt is in its infancy, and to say the least, we still have a limited experience. We started robotic surgery about 2 years ago. I started to put my hand on the robot few months ago, and I was quite happy that in few months I was able to do the largest number of robotic surgery in Ain Shams University in the past few months. The robot we are working with is a CMR Versus from Cambridge Robotics. It's not the Da Vinci. It has some differences from the Da Vinci, which is the gold standard of robots. They have a very long experience in the USA and worldwide. The Versus is a new one, and it's different in some aspects. Some are advantageous, like the open console, and other aspects that we will see in this small presentation. Endometriosis has been a neglected part of the female complaints in this country, and we didn't have a multidisciplinary team till 2 years ago, when we formed this team with my friend Hassan Morsi. This team contain or have a very brilliant bowel surgeons, mainly Professor Tariq Youssef, Dr. Ahmed Ali, and Dr. Karim Kamel. We have 3 urological surgeons. We have 2 MRI experts in imaging of endometriosis. We have pain management consultant and 2 anesthetist consultant expert in advanced minimal access surgery procedures. As you know, endometriosis is a chronic inflammatory disease characterized by the presence of the endometrium like tissue outside the uterus. The hallmark of endometriosis is pain. Pain during the menses, during intercourse, chronic pelvic pain, dyschezia, dysuria, in addition to infertility. There are several types of endometriosis. Some classifications say that there are 3 types: superficial ovarian endometrioma, deep infiltrating endometriosis, but also recognize distant endometriosis like the ones that we have related to C-section scars, for instance. To know the burden of endometriosis, we have to say that about 10% of women in their reproductive age will have endometriosis. 40 to 50% of women and adolescents presenting with pelvic pain, 30 to 40% of women with infertility, and deep infiltrating endometriosis represent about 20% of endometriosis cases. That's 2% of women. The deep infiltrating endometriosis can affect the uterosacral ligament, the vagina, the rectovaginal septum, the pelvic side walls, the bladder, the bowel, the ureter. And the problem with deep infiltrating endometriosis is the difficulty to reproduce the same type of surgical technique with different patients. For the diagnosis, we have the patient symptoms: vaginal ultrasound, rectal ultrasound, MRI. These are the main tools for the diagnosis of endometriosis. The dilemma of managing endometriosis lies in the fact that there are variables that we have to consider, like the age of the patient, the severity of pain, the desire for fertility, the acceptance and tolerance of hormonal treatment, because in this country, some patients will totally refuse any hormonal treatment, and finally, the acceptance of complex multidisciplinary surgery and its possible complications. If we speak about medical treatment in brief, we have first-line treatment like progestogens, the Dynogests, the second line like GnRH agonists and antagonists, and others like aromatase inhibitors and NSAIDs. If pain is the main problem, then we have 3 options: to give either analgesics like NSAIDs, hormonal treatment, and surgery. But if infertility is the main issue, the main problem of the patient, then hormonal treatment is out of the equation, and we are left only with surgery and assisted reproductive techniques. The endometriosis surgery with the robot is very similar to the surgery with the laparoscope. The robot doesn't do the surgery. It has no brain. It's just a tool that you control it while you're sitting comfortably and remotely from the patient table. So from the console, you control the robot arm. In the vast majority of the cases, we use 4 arms, 1 for the camera, and 3 arms that you use during the surgery. Usually we have a monopolar scissor, a bipolar Maryland, and a traumatic grasper. So you still need an assistant for manipulation of the uterus and sometimes for suction irrigation. One of the advantages of robotic surgery is that you can do the surgery while you're sitting and relaxed. So people like myself can hope to work till their 80s. So it's very comfy to do the surgery while you're sitting. In addition to the fact that there is a wide range of mobility in the arms of the robot and in the tools. It's unlike the laparoscopy tools, which are straight tools. There is no movement in the rest. So you have that. In addition, you are the one who is holding the camera. And this is a major problem for anybody doing laparoscopy, because your assistant will show you what he thinks that you want to see, not what you actually want to see. So you have nobody to blame regarding the view but yourself in this case. We had good number of endometriosis cases, but we have to say we built on our experience in laparoscopic surgery in endometriosis. The learning curve in the robotic surgery is a bit steep, but we have to say that it really needs a good laparoscopic surgeon to master and handle robotic surgery. Now, I will show you in brief one of the cases of endometriosis. If we can dim a little bit the light in the hall, please. Endometriosis is quite complex surgery because everything is stuck together, and the amount of fibrosis that the surgeon will face and the disturbance in anatomy is unmatched in any other surgery. So one of the first steps that we need to do in any endometriosis surgery, whether we are doing this robotically or laparoscopy, is to do ureterolysis. Because without seeing the ureter all the time during the procedure, you have a very good possibility of injuring either one or two ureters. We have another problem in this country when we are faced with versions where we cannot use a uterine manipulator, so we have to do a sort of anchoring of the uterus so we can have some traction. As you can see here, with the robot, with the robotic arms, you can do ureterolysis, which is usually much easier than laparoscopic dissection. I'm using one of the robot arm for traction. Actually, this is my assistant. And using the other two arms for identification and ureterolysis. One of the problems in robotic surgery, especially in this robot, is that we don't have an ultrasound dissector so far. So if you are used to use a harmonic, it's not readily available till today in the Versius robot, but it's available in the Da Vinci robot. But again, even in the Da Vinci robot, it doesn't have hinges and joints. It's still a straight instrument. So I think that robotic surgery in endometriosis is very important because of the mobility of the instruments, because of the ability to see and dissect the deep pelvic spaces, especially the pararectal spaces, and the dissection of the rectum from the back of the uterus. And as you can see here, these tools are very helpful in that dissection. Hopefully, with time, we will have more and more doctors being trained on the robot available in Ain Shams specialized hospital. The problem with the training in the robot is that you can just stand with one of your fellow surgeon and learn the technique and then go to do the surgery. There is a structured training. You need an e-learning, and then you have to pass the exams and the modules that you study. This is followed by virtual training. And for this Versus robot, for instance, there are more than 16 modules the surgeon has to get, has to pass each module at least once. And then there is a dry lab training. And then finally, you got your license and you are allowed to work on the robot. The license now is not given by an institute or your university. The license is given by the company which manufactured the robot. In the past 4 months, we performed over 16 cases of endometriosis, 6 cases of robotic myomectomy, 3 cases of scar niche repair, and 5 cases of robotic hysterectomy. And the results were very satisfactory, and we have no major complication. So again, it's the same concept. You are the one who is controlling everything. You are the one who is operating, whether you are standing at the bedside of the patient or sitting remotely, but still the surgeon is the one who is doing this magnificent art. Thank you very much.
Thank you, Professor Amr Husseini. Next session is about the training in the minimally invasive unit in our university hospital. I want to say that this unit, since its existence, something like 30 years ago, has passed through periods of prosperity and periods of quiescence because of lack of some resources. Not to tell that radical hysterectomy and with lymph nodes and laparoscopic bladder suspension were there in the unit in the early 1990s. Again, in the past couple years, the unit is not just flowering, but it's booming actually. And let's share this experience with the director of the unit, Professor Muhammad Said Ali. He's a professor of obstetrics and gynecology and director of the minimally invasive surgery unit in Ain Shams University.
Assalamu alaikum. Hello everyone. We are very proud today to be with my fellows, my professors, my chairperson, and we are proud today in this prestigious conference, and I want to thank all audience, and we will take you in a few minutes away from the patient diseases, and we will focus on training because we hope that university is the arm of spreading knowledge and training, especially in the field of laparoscopy, hysteroscopy, and early cancer detection. This is where we grow. This is the Ain Shams University Maternity Hospital, and we all proud of being staff member in this huge, large hospital specialized only in female maternal, gynae, and obstetric disease. Actually, we have 2 units, early cancer detection unit and minimal invasive surgery. Both are the arms where we start training and learning in this hospital. The early cancer detection unit is started since 1981 by the Professor Dr. Muhammad Bayoumi Samour. He put the first start for early cancer detection at that time. Our mission to promote excellency in practice of women's health in relation to disease of the female genital tract and be responsible to maintain standard of training and professional development. Our structure is clinical, diagnostic operative rooms, colposcopy, hysteroscopy, and a part of a huge department about pathology and cytology. And this is famous on this unit, that both pathology, cytology doctor sharing surgeon in their management of malignant patient and early cancer detection. We have also cytology, fine needle aspiration, pathology, as we say, not only for gynecological and even for non-gynecological cases. The unit facility, we have clinical sector, 2 examination room, colposcopy room, including video colposcopy, 2 operating theater, and 2 advanced hysteroscopic sets. The unit surface includes cytology for, as we say, gynae and non-gynae cases, fine needle aspiration, including breast fine needle biopsy, hysteroscopy, diagnostic and therapeutic, and the pathology, including frozen section, colposcopy, and laparoscopy. The training and practice we are insisting to have is not only for the doctors in Ain Shams University, and this is the idea and the important thing I want to get this message. We start certificate in endoscopy in gynecological surgery. This certificate will be for around 2 years. Through many slides, we'll navigate that we start with any doctor, specialized, either master degree or MD degree. Then he will practice till reach at least mastering total laparoscopic hysterectomy and managing complicated cases. Another issue and another arm to repeat training over 1 month's duration for concentrated training, practical and evident. This is the early cancer detection unit. This is in the first floor of the maternity hospital, including the theater, the pathology, both together, hand in hand. For the workshop, we try to concentrate on many aspects, including scientific and practical things. We have to gain theoretical knowledge, including indication for hysteroscopy and different energy source, identified hysteroscopic instrument and system, be aware of different difficulties and complications and how to overcome them. Also simulate and training on telebags and simulator before going for actual operation. Observe few cases of operative hysteroscopy, then we are going to identify different situations like hysteroscopy role in infertility or other medical problem. We have integrated units and hopefully enough the patient will take full service, including clinical diagnosis, operative and post-operative management. About certificate in endoscopy in gynecological practice, we provide trainee with additional advanced module, allowing them to undertake more in-depth studies in specific area of gynecological endoscopy. We start by a level of master or MD and complete the clinical training and working in clinical practice. As we say before, this includes colposcopy, hysteroscopy, and laparoscopy, 1 year duration, 4 courses, 18 credit hour, and 13-hour clinical training weekly. Dr. Amr Husseini, the head of our department and the former head of early cancer detection, he is the first one who started this certificate, and thanks God, I am the following for him. Also, we have a very prestigious, active coordinator, Dr. Radwa Rashid. when we talk about university diploma, we should focus that the training include all what the candidate needs, from mastering colposcopy and hysteroscopy and laparoscopy. And we run for a step-by-step approach. We have a huge staff of Ain Shams University with collaboration with other centers and other doctors. Our target is to certify at least 18 candidates every year. And we start, as we say, from basic level of laparoscopy, hysteroscopy, and colposcopy to reach advanced. We have integrated theater rooms, teamwork, and of course, patient safety is our first target, because we all think that the patient should receive the best intervention by the best hand in the best place. Large part of the training is done on telebags and simulator, especially in laparoscopy. The patient have to have many times of training. No need to rush for theater, and we say almost always be trained before doing laparoscopy. In diagnostic hysteroscopy, we insist that at least he do 500 diagnostic hysteroscopy to start operative hysteroscopy, like resection of septum or resection of myoma or getting endometrial resection. The module, as we say before, either condensed over 1 month or it is 1 year certificate reaching 2 years according to the planned program. Still, we are going for regular workshop, and actually this workshop increase both the candidate and the trainee activity and experience. So we are going on, and we continue till reach a good standard, inshallah. Teamwork is the most important in our department, and will continue. And we promise in Ain Shams endoscopy unit to be in a good place as expected. Practical supervised training is the most important, and of course the certificate carry the importance of a clinical data, of a good practice, and to avoid complication. This is our unit and how to contact, and I want to thank all the audience and chairperson, and thank you.
And now it's our pleasure to hear from Dr. Ali Kokmetin about the robotic assisted surgery and the management of complex gynecological oncology cases. Dr. Ali is a consultant and lead for laparoscopic surgery, gynecological oncology at the Northern Gynecological Oncology Center in Getchell. He trained in obstetric gynecology and the Wessex Ordinary before moving to Newcastle to complete a higher degree in ovarian cancer research. In 2009, active in the training of laparoscopic surgery locally, regionally, nationally, and internationally. It's our pleasure, Dr. Ali, to hear from you.
Thank you very much. Thank you for the kind introduction. I would like to thank my friend Professor Amral Husseini and the conference president Dr. Al Gamal for their kind invitation, and the scientific committee. It's always a great pleasure for me to come and meet you guys here and make presentation. Today I'm going to present 3 cases of complex cases. I didn't put gynecological oncology because I've got one general surgery patient. Before I start, I wanted to show you the manipulator that we use in Gateshead. These are anal sizes we use instead of uterine manipulator because of the 3 reasons. They're cost effective as they are reusable. They're dynamic because you can move around, and it avoids uterine manipulation. And this is the robotic ports we use to use Da Vinci robotic system in Gateshead. Usually 20 centimeter between the pubis and the operating field. And if we do upper abdominal surgery, like periaortic surgery, we turn the robot around and look at the upper quadrant. So we've been using the system for 2 years, and I've been a laparoscopic surgeon for many years beforehand. And doing laparoscopic surgery and then moving to robotic surgery, you must adapt your operating because it is quite different compared to laparoscopic surgery. So 3 cases today. One is an 83-year-old patient with cervical cancer. The reason we did this robotically because she was 83. We discussed in the MDT, and we thought the benefit of minimal invasive surgery outweighed the risk. So we did laparoscopically. The second one is a 74-year-old male patient with a colorectal primary tumor and had a bilateral node involvement. Actually, I was asked by one of the general surgeons to do this operation because they don't do lymphadenectomies. And the case 3 is a 53-year-old patient who had excision of left periaortic nodes with mobilization of left colon. This is a different technique. I'll show you how we're going to do that. First of all, the male patient, as you can see, the male pelvis, it's quite narrow compared to female anatomy. And this tumor was deep in the pelvis, even below the internal ilia. As you can see, this is the obturator nerve here, and the tumor was below, between these 2 branches, and you can see that on the MRI scan. It was quite a large tumor. So the colorectal surgery was done first, and then we did the second one. But I'm going to show you another case. This was another male patient with the video is going to be another patient who is going to have bilateral common iliac lymph nodes of a 35-year-old. Going to the third case, this patient was a recurrent synchronous FIGO stage 3 uterine carcinosarcoma, as well as FIGO 1 stage endometrioid adenocarcinoma of the right ovary in 2021. 3 years later, we also did bulky lymphadenectomy for this patient. And 3 years later, she recurred with periaortic lymph node following chemotherapy and also pelvic radiotherapy. So this was the CT scan. As you can see, the lymph node was only 12 millimeter, and it was very posterior, just next to the aorta and below. So the standard approach for this one was through the mesentery. So in front of the aorta, we went below the IMV, and we had a medial approach. But this was difficult, and I had a suspicion that we might have missed the lymph node. I wasn't sure if the lymph node we removed was the lymph node here or not. For this reason, we did another CT scan in 2 months' time to see if the lymph node was still there. And it was there. It was bigger. So this was bigger. It was 14 millimeter. So this time, I decided to go laterally. I decided to mobilize the bowel medially. As you can see, colon coming down like this. So I call this transretro approach. I described this before laparoscopically. We did a case, and the reason we called it transperitoneal because we go transperitoneal into the abdomen, but retroperitoneal because we mobilize the bowel. So this was, when you mobilize the bowel, the advantage would be that you can see the ureter, you can see the aorta quite clearly to be able to remove the lymph node which was located here, just under the renal vein. And for this, I asked for the general surgeon to help me because she had previous radiotherapy and previous mobilization and extensive surgery. we work quite well together. So my videos altogether is about 20 minutes, so I might need to fast forward. So this is the radical hysterectomy first of all. The videos are fast, as you can see, because I need to show you a lot. So standard approach, dividing the IP ligament and open the retroperitoneal space. The vision is quite good. It's important to zoom in, and it's important to use your assistant as well as your third arm to move with the operation. Like Amro said in his presentation, in robot you don't have the ultrasonic device, but you have to use a lot of monopolar. And there's a quite clever bipolar device as well, which is quite fast. It's called vessel sealer in Da Vinci system. It's very effective, very fast, but you don't have the fine dissection. So for this patient, we did obviously the sentinel nodes first, and I'm not going to show that. And then radical hysterectomy. I might fast forward as we go on. So it's important to use the third arm. You can see so you can see the vessel sealer, quite effective, and I'm using in combination with monopolar scissors. So when there's vascular structure, I use the vessel sealer, which is bipolar device. So this is the manipulator that we use. As you can see, when you do the bladder dissection, you move the manipulator anteriorly, and if you do your dissection laterally, you move it laterally. Developing the spaces here. As you can see, most of the time, you don't need your bedside assistant, because having the third arm is very useful. It's different from laparoscopy because the interaction is less. You do most of the operation yourself. You can see the uterine tunnel development here. You see the nerves. The reason I didn't ligate and cut the IP ligament, because it helps with the operation. If you cut this at the beginning, it's going to interfere with the operation. This is the development of Okabayashi space, and you can see the nerve. I'm lateralizing the nerves and dissection the uterosacral ligament medially. Assistant is using the suction there. Again, you can see the Okabayashi space and the splanchnic nerves and hypogastric nerves. We preserve the nerves here. As you can see, the bladder branches for the bladder dysfunction. And since we've been doing nerve sparing radical hysterectomy, the urinary dysfunction has been minimal. We hardly had any patient with urinary problems. And then further dissection. Then we're going to do colpotomy. I need to fast forward because I'm running out of time. So this is the male patient. As you can see, the pelvis is quite narrow. This is the common iliac artery, and this is the positive lymph node. What I have noticed in the colorectal case is that the lymph node is more vascular. You'll see more vascular. You see these vessels. We don't often see these in gynecological cancers, but this was rather different. So you need to be careful dissection, not grasping the lymph node itself, but grasping the edge of it. So you can see the vein there, common iliac vein. And actually it is sitting in front of the sacrum. So using the monopolar energy with small bites, it requires quite patience in robotic surgery compared to laparoscopic surgery. As you see, I'm pushing the lymph node because if there's nowhere to grasp, you just push, pull. In robotic surgery, there's a lot of pushing as well, rather than pulling. You can see, we don't see this kind of vascularity in cervical or other gynecological cancers. So it was quite different. It's sticky here. We managed okay. So this was the lymphadenectomy. I'll move to the last video next. If I can make this moving. So here you can see this is the mobilization of the bowel. So we need to put the ports in different ways so we can work down in the pelvis on the side and also up to the splenic flexure. It took quite a while. Long part of the operation was to mobilize this bowel. And like I said before, I asked help from the colorectal surgeon on this occasion because it was a robotic surgery. You know, the handling of the bowel is quite delicate because there's no haptic feedback. So once we did this, I'll move forwards again because we are running out of time. Now you can see the IP ligament. We've mobilized the bowel fully. And the IP ligament, we are looking for the ureter. To find that we mobilize the bowel a bit more, we need that space. And going back, finding the ureter. So if the lymph node is going to be here, this is the lymph node. So we need to divide this to be able to have better access. This is just an IP ligament. It's not functional because she had previous surgery, previous pelvic clearance. As you can see, this will be quite difficult to do from the midline approach. So we got the vessel sealer again to remove the IP ligament, which is joining, draining into renal vein. Left renal vein is here. We use this cruciotomy. This is quite gentle instrument. and this is the lymph node now. So the actual lymph node excision was the shortest part of the operation, but to prepare for the surgery and the fields, it has taken quite a long time. As you can see here, we're trying to avoid grasping the lymph node. As you can see, we found the right lymph node this time, and it does look quite abnormal. And this was positive. It came back as positive, but they couldn't differentiate whether it was endometrial or ovarian cancer. So the plan was to give her further chemotherapy. The patient completed chemotherapy recently, and at the moment she's disease-free and she's doing well. Thank you very much for your attention.
Thank you, Dr. Ali. Our next speaker is Dr. Bart de Vrie from Belgium. He's a gynecological endoscopist at ZNA Campus Cadix, one of the state-of-the-art centers for endoscopy. He's the co-medical director of the International Society of Gynecological Endoscopy. Dr. Bart de Vrie.
Yes. Thank you very much, ASOGIC 27 for this kind invitation, especially Professor Hatem and Professor Said. I was very happy to be invited also for the hysteroscopy workshop. I congratulate everybody for this fantastic workshop. As you see, in fact, I wanted to say I'm maybe a little tired because I was up in the morning at 5:30 because I went to see the pyramid region. So I'm very delighted that I saw your ancient history. But if I can talk about hysteroscopy and hysteroscopic myomectomy, I am wide awake immediately. I work in Belgium, in Antwerp. I also, in the Cadix Hospital, I'm also affiliated to the University of Antwerp. I'm medical director of the Endoscopic Training Center in Antwerp, and I'm going to be the medical director of ISGE. I follow up after Bruno van Herendaal, and I'm going to take over in May to be the main medical director. ISGE is a worldwide organization, and of course we want to spread the word about minimal invasive gynecological surgery on all continents. During our meetings, during our personal workshops, and of course our own accreditation system, but also we want to help out, we want to reach out to all local initiatives through our boards of teachers, because we have teachers that we can send out all over the world to help out in local workshops. But now, fibroids. So in summary, a little introduction. I will talk you about preoperative imaging, because the preoperative imaging is of the utmost importance. Then, and some different techniques to tackle the myomas. Of course, I'm talking about the submucous myomas, and then to give you some take-to-work messages. So, very rapidly, we know treatment options in symptomatic fibroids, non-surgical therapies, surgical therapies. I'm not going to go into it because of your 15-minute time that is running. And of course, if we don't get there through non-surgical therapies, we have our surgical therapies, the hysterectomy, of course, which is our 100% success therapy. But the last years, there are more and more women who don't want hysterectomy and need and ask for myomectomy, and of course, in the cases with subfertility. I mentioned also some alternatives. Important is when we choose a certain technique that we absolutely don't want to harm the patient. We have to think about that always. And when we think about harming the patient, it has to do with complications. And I just want to mention this very important book that was released this year by my colleague that is here in the audience, and he will give a presentation just after me. This is the book of Complications on Hysteroscopy by Dr. Raul Manchanda and his co-editor, Dr. Antonio Simone Lagana. But also, I want to point out the guidelines of the ASGE on hysteroscopic myomectomy. These are quite new guidelines from 2021 on this subject. But okay, pre-operative assessment. So it is true that we want to know, before we go to the OR, we want to know which type of fibroid is it, the number of the fibroids, the size, or it is better even to know the volume, and what is the residual myometrial thickness towards the serosa. We want to exclude malignancy, correct preoperative anemia. Do we have to pre-treat our fibroid? Yes or no? And in the end, we have to choose the system, the instrument where we are going to do the myomectomy with, and to decide whether I'm going to do it myself or maybe ask a more experienced colleague. And in these pre-operative assessments, we have a couple of tools. We have our ultrasound and we have our diagnostic hysteroscope. So, and this is how I do it in my hospital. So at the left side, we have our ultrasound to look at the uterus, the one or several fibroids. So we put the Doppler, so we can do some differentiation between adenomyoma and myoma. And then I have like the hysteroscopy tower just next to it, and I go for hysteroscopy diagnostic. And because I want to see this fibroid with my eyes, this is the best way to have an idea of the fibroid preoperatively. And immediately after the hysteroscopy, I redo the ultrasound, because with the fluid that is still inside, in fact, we do a saline infusion image. And then, by doing the ultrasound, hysteroscopy, and the ultrasound, we can, in fact, do our classification, because we want to know if it's a type 0, completely into the cavity, a type 1 or a type 2. The type 2s are more than 50% into the myometrium, of course, are more difficult to tackle. And this, in fact, is the more simple classification that we use all the time. So again, it's the same thing. It's the old classification that is used by the ASGE. So 0, 1, and 2, because we want to know if it's going to be a difficult myomectomy, yes or no. And we tend to say the zeros is for everybody to do. The type 1s, if they are not too big, can be tackled by hysteroscopy by almost all gynecologists. But what about the type 2s? The type 2s are more inside the myometrium. They can be more dangerous. So a smaller type 2, you could do it if it's like a larger type 2 myoma completely into the myometrium. You could doubt if it's like a good indication for hysteroscopic myomectomy. And so we talked about classification, because what the other more important thing is the size, or better said, also the volume of the myoma. Here we see that if we have a myoma of 3 centimeters, the effective surgery time is about 30 minutes. So 3 centimeters could be doable. in hysteroscopy. But if we say 4 centimeter and we see how much the resection time is, we are over 1 hour. So the limit of doing hysteroscopic myomectomy is somewhere between 3 and 4 centimeter. Okay. Now, in ASGE, as I told you, we do recommendations about hysteroscopic myomectomy, and the recommendation of the ASGE, in fact, is that the ASGE classification is okay, but the step W or the LASMAR classification is even better to do your classification. So, this LASMAR classification, and here you see Dr. LASMAR is even better. It is not about only type 0, 1, and 2, but it is about 5 different features that we have to put in this classification. And then if we take the total score, we can see if it is a low complexity, a high complexity, or you have to consider other alternatives for your hysteroscopy. But let's go now to our myomectomy and the different techniques that we know. Because in fact, we have to choose between a resectoscope or a tissue removal system, between a resectoscope and a shaver. And because there is on the market a lot of different items, instruments that we can use. But the most important stays the resectoscope. We have like our big resectoscope that everybody knows, but we have a couple of smaller resectoscopes also. But the last years, we also have the tissue removal systems, the MyoSure, the TrueClear, and the Bugatti system of Karl Storz. I think, and surely in my country, the bipolar resectoscope is the most commonly used. And what about the techniques we can use with our resectoscope? Of course, we have our normal slicing, and then for additional, what do we have for additional techniques to tackle the intramural portion? We can do hydromassage, we have the cold loop technique, and then some other help to tackle the deeper part in the myometrium. So first, we just go over the classic slicing system. So the slicing, we always start at the easy part. We just slice until the complete intracavitary part is done. And then we end up with our intramural part of the myoma. And when we do this with the slicing technique, which is okay, it is a little difficult, but we have to keep in mind that we always, because of the heat, we will have some collateral damage, which we don't want with the infertility patient. And that's why we try to have some extra help from some techniques like hydromassage, like you see here, by closing our inflow and then opening again and closing again. We have this movement of the intramural part towards the cavity because of the myometrium contractions. This is hydromassage. And then, just to show you some little tricks that we have to tackle the intramural part with our loop. And here you see our normal loop. And of course, we have to go in the pseudocapsula, the little space we have between the myoma and the myometrium. We just have to go behind it, do your slicing, and whenever we have the possibility, we can try to do a help with cold loop to get this fibroid out of its pseudocapsula. You will see right away how I try to get this myoma out of the capsula with a little cold loop movements. And what happens next? We have also the cold knife technique of Dr. Mazzon, who has these special electrodes without electricity to try to get the myoma out of its pseudocapsula. And here you see the technique of Dr. Mazzon. So it has a first part, which is the normal slicing, which you will see here. And this is the normal slicing as we do all the time. But then he takes out the resectoscope and he changes the loop towards one of his cold knife loops. And you will see here how he gets the inner part of this myoma outside of its capsula without using any electricity. So this technique possibly is better for the infertile patient. And then this part comes out, and then this bigger part that was intramural, he does a slicing procedure to tackle the last part. So I go a little quicker for the time. And then you also have the lens technique from our friends from China. And they do also the dissection of the pseudocapsula, but they do it with a hot Collins loop. So they go in the pseudocapsula to try to get the big intramural part out, as you see here. And then they don't do the slicing, but they go with a grasper, a special grasper inside, and then with ultrasound control, they try to get the bigger parts out. So because of the time, I go a little quicker. So, and then we come to the morcellators. So the morcellators are fantastic, the shavers, but they are fantastic for soft tissues. The design was already old. It is from Dr. Emmanuel from Holland, and he transformed a orthopedic shaver into a gynecological shaver. And why it is so good? Because it is surely a lot faster than our resectoscope for soft tissues. There are a lot of advantages, but the good advantage is that you don't have chips that are in your view. There is a shorter learning curve. Possibly there are lower complication rates, but they are much more costly. So I'm going to conclude as a take-to-home message. I would suggest everybody to do to try to predict the degree of difficulty of the hysteroscopic myomectomy, preferably using the step W classification. You have to counsel the patient regarding possible 2 steps. You have to know your limits, and you have to do a lot of practice, preferably in workshops. And as the last take-to-work message, I think at this moment, the instrument of choice is for the myomectomy is the bipolar resectoscope. And the superiority of the shavers is clear for soft tissues, but I think the evidence is not yet convincing for myomectomy yet. So I thank you very much for your attention. And just a very last slide to tell you that we are having the annual meeting of the ISGE in Zanzibar this year from the 21st to the 24th of May. So I welcome everybody to this meeting, also with workshops and a nice Congress curriculum. Thank you very much.
Thank you. I would like to invite Dr. Raul Manchanda, Director and Chief Gyne-Endoscopic Surgeon at Manchanda's Endoscopic Center. He's covering the heading the endoscopic gynecological unit at Pessary Hospital and is associated with Roswell Women Center as senior gynae endoscopic surgeon to talk about complications of hysteroscopy, diagnosis and management tips.
Okay, I'm going to be a little different here, if I may. Good afternoon, everybody. And I'm here to play spoil sport because I'm here to talk about what actually happens behind these wonderful videos that we have. And that's about complications. Now, I started differently because this is a video which is of a lady who'd had 2 previous cesarean sections. She was postmenopausal, about 75 years old. She had a mass in the uterine cavity, and she had blood accumulated, of course. So we all know that hysteroscopic surgery, at least back home in India, we look at it as a lot of us look at it as a minor surgery. But this is to show you that it's not really a minor surgery. It is something that we need to take cognizance of, be more, okay, let's go back. Yeah, okay. Can somebody help me with the pointer here? There we go. I'm going to move it further ahead. So, what can happen? This is the same video, of course, and you see, we took that mass out, but it was taken with an ovum forceps out. And what really happened is there was a perforation and there was a bowel injury. Luckily, it was diagnosed immediately post-operatively. You'll of course have the signs and symptoms. The CT scan was done, and we had her in the operating theater within the hour. The surgeons came in and repaired the bowel, and she did well. But this is something that can happen, and we need to obviously take cognizance of it and not treat hysteroscopic surgery as, how do I go to the next slide? How do I move the slide? No, next slide. Yeah, okay. So, this is what I'm going to talk about, and that's my name, and that's where I come from. Thank you to the organizing committee, all my friends in Egypt. This is my second in CHAMS conference, and Bart has already spoken about our book, so I won't talk much about it. And when I looked at, these are the other books that we have written, some of my passionate topics, which is intrauterine adhesions, of course, beside complications. We released this book in Italy and Professor Malzoni's conference a little while ago. This gentleman that you saw is Professor Gawande, and he has written books again, which all of us will relate to, I feel. So if you get your hands on them, do read them. Now we need to separate a complication from negligence. Back home in India, that's the thing. We look at a complication as being negligent. It isn't. If you're doing surgery, you're going to have complications sometime. This is a paper by Professor Loffer. Some of us will know him. And you see very clearly the part that I've outlined is that complications occur, he says, when proper surgical techniques are not followed or equipment is not okay. But it can also occur if proper surgical techniques on the right patient has been applied. So if we're doing surgery, we will eventually have a complication. The point is to diagnose them and then treat them and manage them. When I was looking at complications, this is actually the list of complications. And we'll look at one by one, time permitting, of course. The more common ones is what I've marked, which is mostly entry related in hysteroscopy. The more furious ones are the distension media and, of course, the gas embolism. Let's go on forward. Epidemiology. It happens more commonly with operative and hysteroscopies where the anatomy is distorted, whether it's a fibroid or Asherman syndrome. This was a registry in the Flemish area which had 4,000 hysteroscopies which they looked at. And again, they said it was most commonly with things like Asherman syndrome and, of course, fibroids. The most common one, of course, is more when you're entering, which is cervical laceration. Here you see the same conclusions. When we talk about office hysteroscopy, the most common complication is of pain and vasovagal symptoms and nausea, of course. I'm not going into the details of this because we have less time, but just a point about each complication is what I'm going to talk about. Here you see a diagram as to how to manage a vasovagal in office hysteroscopy. Anesthetic complications. A lot of us are doing hysteroscopies under anesthesia. I listen to my anesthetist. If he tells me there's a problem, stop, bring the patient back after reviving the patient. Don't be heroic. You can have complications, but it's all about teamwork. Remember, this is important. We can't operate individually. We're not a one-man army, even though in robotics, you are doing most of the work yourselves. Now, that's my team, and that's all of our teams. If you have a well-oiled team, it functions well, you avoid, that's the first thing about avoiding complications. Okay, positioning of patient, believe it or not, if you have even 15 minutes of surgery and if the patient is not positioned properly, you can have these injuries which need to be avoided. Distension media, again, the most problematic one of these. Remember, and I'm going only to, we all know of TUR syndrome, what are the types, what is the most commonly and the best distension media to use, normal saline, especially with the advent of bipolar resectoscope. I'm going to skip over these slides and come to how to avoid the TCRE syndrome, which is one of the most dreaded complications, of course, because of what we all know of cerebral edema as well as lung edema. We can lose our patient there, electrolyte imbalance. How do you prevent? You use bipolar, you use normal saline, you use, you reduce the time, you reduce the pressures, and hence try and reduce the inflow. Remember, your deficit level is very important, the amount of fluid going inside and what's coming out. And there are strict guidelines which have been issued by the ISGE. We should never have a situation like this, of course. And there you see it. If you have fluid deficit of about 1000 ml for glycine, please stop your surgery. Again, don't be heroic. Counsel the patient before. You might need 2 sittings. 2500 is for normal saline. But of course, if you have an already compromised patient by lungs or heart, those deficit levels go down drastically to about 500 to 700 ml of fluid. This Bart has already spoken about, Professor Bart has spoken about, so I won't say, but remember, even 1 centimeter of fibroid difference will increase your fluid inflow to a large extent. How do you avoid them? Use appropriate distension media, use appropriate delivery systems, have a good pump, try and avoid vascular channels, keep your pressures low, and a very meticulous accountancy of fluid is important. You have a staff nurse or a circulating nurse that's doing this count every 5 minutes. And that's actually what we should do. So we had the birthday of our first, the father of the nation literally was on the 2nd of October. And this is our first prime minister. And this is what he said, which is very difficult to do in a case of a complication, but you need to approach it calmly. Surgery-related complications, again, rushing through it. You can have a uterine perforation. It could be a simple one with just a mechanical instrument, or it could be with obviously laser or cautery. Remember, obviously, we don't want the second one because then you need to do a laparoscopy or a laparotomy depending on what you're proficient in to see how far the current has gone and manage them. People often talk about hemorrhage. I don't see, all of us are gynecologists and we've dealt with postpartum hemorrhage. The amount of hemorrhage that you have in postpartum hemorrhage and how we manage it, we can easily manage this. But generally the protocol is similar to what we manage there. Now, the most common complication as far as the patient is considered is this, which is failure of resolution of presenting symptoms. She comes to me, she says, I have this problem. I say, okay, I'll do a wonderful hysteroscopy, but she doesn't get relief, whether it's for bleeding or infertility. Remember, selection of your patient is very important, and of course, learning techniques to do it properly. And if you do that, you need to counsel the patient to tell her that you can still have this problem despite doing doing the procedure. So I'm going to show you a few videos which are very old, and hopefully now this is an old video of mine which of a patient who's infertility related came to us, and this is a false passage. They were obviously putting the embryo in the wrong area. So this not only can be diagnosed, but at times managed also. A similar video of a false passage, similar history patient. You see above is the normal cavity. I've moved the video ahead. Below is where they're actually putting in either the embryo or the semen. So it sort of simulates like an Asherman's cavity. So this is a paper by Alka and Atul Kumar, who talk about how to diagnose the false passage. And it's important to recognize the anatomy. Again, short videos, which I'll talk about, we're using laser here. And this is the laparoscopic part of it, because she's a case of infertility and we were going in the wrong area. But luckily, we did not perforate. And if you see here, you see a small hematoma at the right side where you go. It would have been a complex perforation had we perforated, of course. So let's go on further. Another of our complications, a perforation with a resectoscope at the fundus, not bleeding, laparoscopy done, managed, and that was the end of that. I talked about anatomy. Intrauterine anatomy is different to laparoscopic anatomy. This is a case of Asherman's, where again we're dissecting and we're opening up the cavity. And you see here, there's a perforation at the fundus, there's bowel moving at the back. But with a mechanical instrument, I know how far one has gone, and it's a very small perforation which we manage, and of course we get out. That lady has done well, of course. I said about negligence, the difference between negligence and complication. This was a case in India where a couple was telling their son to do surgery. So when you're not supposed to be doing something and you do it and you have a problem, that's when it becomes negligence mostly. There are no minor surgeries, I've already said. Air embolism, again, something that we have encountered, one of the most drastic things, using the smaller telescopes, not using bubbles creating instruments, not using weighted speculum, flushing the tubing, not giving with fluid, not giving a head low, are all ways of avoiding them. 2 minutes I'm going to take on the second victim. And the second victim is the doctor. Because while none of us want to have a complication, when we have a complication, this is what we undergo. And I think all hospitals, universities should have a small cell where these victims, which is us, after are gone, we can go anonymously, are supported. Of course, you need to do a proper recce of it, and they can be helped, because when what they go through is, like I've mentioned here, is a lot of emotional upheaval, getting out of their surgery. They even stop doing surgeries, but it's important to be determined to avoid isolation, to do things that you will get your mind off it. For me, of course, is playing golf. So I do that, and that is our president's house, where I recently had the privilege of going and playing a game of golf. But we all unwind in different methods. Again, this is a resident in the NHS system who left because of such complications that he had during surgery. He quit the profession and is now doing something else. I can't stop without talking about the Global Congress. When we were going through COVID, another problem, another complication, this was a statement that they said, and they said by and large hysteroscopic surgery is quite safe as far as transmission of COVID goes. You need to give enough time between cases to prevent transmission. In the end, a few take-home messages like most speakers have given. Have a good friend in Egypt, so you can come and meet everybody here and partake. Mine is Munir Mustafa, and then I have been able to meet all the wonderful professors here. There is a learning curve to hysteroscopy and any surgery. We need to respect that. Books on complications have been written because they occur, so we need to again respect that. A quality staff and team, which is what I showed in my slide. Your team is most important, quality equipment. Don't compromise on it. They're your eyes. Training and technique, knowing your tissues, and ultrasound guidance for hysteroscopy can be of assistance. But most importantly, a high index of suspicion and vigilance is most important for all of us. And eventually get yourself a mentor. That's my mentor, my mother, who has taught me most things. Thank you very much.